Todd Thoughton from Thoughton Physical Therapy, here for Ask the Therapist, Ask the PT Live. So I want to welcome anyone here who hasn't been joining us, and I want to welcome back anyone who has been tuning in for our sessions. I'm excited to hear it again and grateful that I'm here again this week to pass along my passion and my excitement to all of you out there in the media. So a little bit about myself. I grew up in North Attleboro, Massachusetts, and I was really been interested in the science part of things and psychology when I was growing up. So I was really excited when one of my high school guidance counselors had suggested physical therapy. I had broken my leg also when I was in high school. So between the science and the psychology and breaking my leg and doing some of my own physical therapy, that really got me into the passion, the field of helping out people. I've been a physical therapist for over 24 years, and it's been an amazing journey for me. I was talking with one of our therapists the other day, one of our managers, Nicole, as we were interviewing some other clinicians to join our team. And she said, do you realize at any one time, we have 160 years of experience in a room at any one time? So I've been really grateful to really work with some awesome clinicians over the 24 years here in the clinic, as well as other facilities that I've worked at before. For myself, I'm really passionate about helping people. And my specialty is I really like to work and address people's mindset, work on their mindset, as well as work on their physical issues that they have coming in. I race triathlons and I enjoy working out a lot, and I enjoy nature. And I'm looking forward to, unfortunately, we have a big snowstorm coming, a blizzard coming tonight, expecting 12 to 18 inches of snow, so I'll definitely be out snowshoeing. And I want to say, so Alana's over here joining me again over here on the side, so if you hear me talking, she's helping me with some other questions. Just another great member of our team. So tonight's hot topic that I'm really excited to talk about is the IT band syndrome. So as a way to give back in the community, I'm kind of taking this through what my eyes are as a clinician with the years of experience that I have, that I think a little bit different than some of the other classic ways that people talk about maybe the IT band or the other injuries that people have. So through my eyes, I'll start off by saying that the IT band, to me, is a symptom of a weak core and not activating the correct muscles and overuse of other muscles. I don't remember the last time I had a patient that came in where I actually touched anywhere of their IT band or anywhere related to their knee, because again, I feel that if we can work on the core, that really makes a big change. It really makes a big change for the person. And a lot of times treating, especially the IT band, is a symptom of other issues going on. So just some basic anatomy that I wanted to go over with you is, so we have, I'm so excited. So I want to thank Emily for getting this awesome spine over here. So again, I'm so excited because this spine that Emily found online for us breaks it down into some of the things that I was talking about. So we have the lumbar spine, which is made up of 5 vertebrae. We have the thoracic spine, which is made up of 12 vertebrae in the green. And then we have the cervical spine, which is made up of 7 vertebrae. What I really like about this model over here, the spine, some of the things that we're going to be talking about today, is we have the pelvis, okay, called the ilium right up over here. We have the femur, which is the big bone, the lower leg bone. We have the sacrum, which is kind of like an upside down triangle, meeting at your tailbone down the bottom. And then in the front, we have the pubic bone. And what I like about this model is that we do have some of the muscles, some of the hip flexor muscle, the iliacus and the psoas, which is some of the muscles in the front of the hip. And at the back of the hip, we have the famous muscles, the gluteal muscles. We have the glute maximus. And then underneath, we have the glute minimus and the piriformis and some of the other hip rotator muscles, which are right through this area right over here. So again, thank you, Emily, we just got this in. I was so excited to share with you guys. All right, so to go back, so we have the lumbar spine, we have the sacrum, we have the nerves that we had talked about before, and then we have the discs in between. So the gluteus maximus muscle is the muscle, is the bottom muscle, the butt muscle right up over here. And that's responsible for extending your hip mostly. Then we have the gluteus medius muscle, which is a muscle on the side over here. And then and that's responsible for abducting the hip. We have the gluteus minimus and some of the other deep rotator muscles and the piriformis muscle, which help to rotate the hip. We have the hip flexor, which we just saw on the skeleton over here, which is in the front, which helps to flex your hip. We have the quadricep muscle on the front of the thigh. We have the hamstring muscle on the back of the thigh. So tonight's topic is we're talking about the iliotibial band, IT band for short. We also have the IT band starts from the crest of the pelvis and comes all the way down the side. So if you kind of feel it in yourself, it's a little band. It comes all the way down to the knee. Then we have the tensor fasciae lata, which is also a piece that sits just a little bit anterior to the glute medius, but it also does the same job. So the tensor fasciae lata also helps to abduct the hip. But besides just abducting the hip, what it also does is when we're in a stance phase on this on my leg over here, it stops the other hip from dropping down. So the glute medius muscle helps with the weight bearing, and every time we weight bear, whether we're walking or we're running, it has to be a stability muscle. The problem with the glute medius and the tensor fasciae lata is that they're not really big muscles. They're a small muscle group compared to the glute muscle. And what I found in many cases is that the glute max muscle isn't working as efficiently as it could, and the glute minimus, the tensor fasciae lata and the glute medius, they overwork, go into spasm, and then we also get some irritation of the IT band, and that which goes all the way down to the knee. So on my model over here of the knee, as we picture, the IT band comes down the side of our thigh, comes down and attaches to the femur, attaches down over here to the kneecap as well, goes towards the lower leg. And what happens when we bend or when we straighten our leg, it can snap back and forth across. So if someone doesn't really have good mechanics, that can be one of the big issues with the IT band syndrome, is the IT band is snapping back and forth across the bone as we're flexing and extending our knee, whether we're walking or whether we're running. We also have, so that's the tensor fasciae lata, we have the IT band. Now, so what is IT band syndrome, or sometimes people call it IT band friction syndrome? It's a common cause of lateral knee pain, mostly among military people that stand a lot. Say, for example, someone might be in the military. It's very common there. So we get the irritation as it rubs back and forth across the femur, and where it has attachments to the kneecap, that can give us a little bit of outside knee pain as well. And sometimes the bursa can also be irritated as well, which will give you the knee pain. So what are the causes of it? So one of the causes of the IT band syndrome, or the IT band friction syndrome, is a leg length discrepancy. If one of our legs is shorter than the other, it can throw the pelvis off a little bit, throw the alignment off, which is going to put abnormal strain on the outside of the knee. It could be bow-legged when someone's legs are turned out, the opposite of knock-kneed. When someone's legs are turned out, bow-legged, that can also cause some symptoms with the IT band. Also, just muscle imbalances. It's my belief that muscle imbalances, or core muscle imbalances, really will change your mechanics. It can send referred pain all the way down to the leg, all the way down to the knee. Again, through my eyes, as we've talked about the fuse box before, the idea of the fuse box is the fuse box powers all the plugs meaning all the way down, fuse box coming from our spine, the plugs meaning your hip, your knee, your ankle, and all the way down the chain. So if we have a strong fuse box and we're turning everything on, then we're going to generate enough power to the hip muscles. If the hips have enough power, then they're going to be functioning mechanically well, that it's not going to strain, abnormally strain the knee, or it's not going to turn the knee in or out, which again, throwing off mechanics on the chain, then people can get knee pain. Who typically gets it? Like I said before, runners, very active people. A lot of times people that have improper training methods, one of my big beliefs is heart rate training to make sure that we're not getting overuse of the same muscles over and over without giving the proper rest. Anyone that doesn't do low back or core exercises, weekend warriors, people who sit a lot at their job for long periods of time without getting around. So what are the symptoms of IT band friction syndrome or IT band syndrome? We can have some pain around the kneecap. So it can be pain all the way around the kneecap, but it's usually on the lateral surface of the kneecap. We can have pain when we heel strike as we're walking, pain while we're running. So we can get pain with the heel strike when your foot hits or your heel hits the ground as you're going to come through your phase of walking or running. We can get it upon impact. And it can also be painful to the outside of the knee. So what are some things that, for the subjective, that patients will come in and tell me certain issues? A lot of times people will have, again, pain on the outside. They might have pain all the way up the outside of the thigh. They might have pain on the top of the kneecap. They might have pain underneath the kneecap. They might say that they're unable to kneel. They might have pain going up and down stairs. These are all symptoms of someone that has ITBN. So objectively, what would I see as a clinician? So objectively, I will see pain along the outside of the kneecap. I'll see pain under the kneecap, on top of the kneecap. I'll see pain on the outside of the joint line. I'll see pain to the touch over the quadricep, the front of the thigh muscle. I'll notice when I bend or straighten their leg, they'll have significant amount of discomfort. If I cross the leg over the other one, when I'm putting the hip or the thigh in tension, they'll also have some pain. Objectively, from a motor control standpoint, I'll also see weakness of the glute max muscle, not able to work the butt muscle on that side. Weakness of the glute medius muscle, which is, again, a stability muscle, not a power muscle. Weakness of the low back, and a lot of times, almost definitely poor abdominal control. Even if someone thinks that they can do a plank, doesn't really mean that they have good core control. I'll also notice spasm on the glute medius, which again is a muscle on the side of the hip. I'll notice, if we look back over here at the skeleton, so last time we talked about the SI joint, which is where the sacrum meets the ilium, the SI joint will be locked up on both sides. I'll also notice some difficulty with the lumbar spine not moving very well. I'll also notice difficulty with the thoracic spine not moving very well. So poor abdominal control, poor low back control, those generally all go along with it. I'll also notice weakness with the ankle muscles, because remember, the fuse box powers all the plugs, so I'll also notice weakness in the ankle muscles as well. So what do I believe is a treatment for working on the IT band syndrome? Through my eyes, as being a clinician working with some amazing clinicians as well, I don't remember the last time that I actually touched somebody's knee when they had IT band or any kneecap tracking issues. So by addressing the core, that is always a good place you want to start, because I found in every single person, over thousands of patients that I've been testing this theory on, is that everybody needs to work on the core. So if we can work on the core and the stability, proximal first to distal, that really makes a big difference. So I would start with making sure that they're actually activating the right muscles. Then I would work on some thoracic spine mobility, because we need the upper back to move well in order for the low back to stabilize. I would definitely assess the SI joints. I'd look at the mobility of both hips to make sure that the hips are actually moving well. I would look at the quadriceps and the hamstrings to make sure that they're both firing and working correctly. So those are definitely a great place to start. I also sometimes use, if they have a lot of tenderness or spasm going on in the hip of the knee, I like to use the KT tape that we can help with some spasm. The cool thing about this is there's so many different colors, and it looks really cool too, but it is really effective. So we can use the KT tape to inhibit a muscle that's in spasm, but to help activate a muscle. So if the glute medius muscle is in spasm, we can help to inhibit that, and we can use it to activate the low back and the glute if we needed to. Awesome. Alon just told me I had a few questions. And then if we need to, then we can do some soft tissue work. Also, you can obviously try some dry needling or some grafts into the area as well. And also, if that doesn't work, we can, try some acupuncture. So we have some more questions over here. So Emily, how's it going, Emily? I don't know if you heard, I gave you a shout out for the skeleton over there. Awesome job. Hi, Tracy, how's it going? So Tracy's question, what exercises should I be doing at the gym to strengthen this? So if we want to work, so one of the things that I really like to start with is I want to start with some really good core control of the abdominal muscles. So that can be as simple as lying on your back, having your knees bent up, and just learning how to contract the abdominal muscles here by pulling your rib cage towards your hips, by pulling your hips up towards your rib cage to get those muscles to contract, flattening out your back and your lumbar spine. And from there, then we try and do some motions in which we activate the lower abdominal muscles. There's different ways to progress those as well. So to make sure we hit the abdominal muscles, add some lower level exercises first until we know that we've built a really good foundation. I see a lot of people when I go to the gym, I think planks are a great exercise to do, but it's something that we really need to work up to make sure that we're doing it correctly. But being able to stabilize your pelvis as you're moving your legs is super important. The other one that I like to start with is just the Superman exercise, which is when we're lying on our stomach, hands behind the head, a pillow underneath the hips, and extending both the upper body and the lower body. And the motion just because, again, we want to control and we want to activate the lumbar spine along the whole spine, as well as the glute muscles. Any exercise, again, a good foundation exercise for the glutes and the lower back are really important. Also, then we also want to work the glute medius muscle on the side. One of the ones that really easy one to start off with is a clamshell. So we like to do all exercises supine, or which means lying down on your back, or any exercises prone first to make sure you can activate the right muscles correctly. Then ideally, depending on your tool level, then we want to work through exercises in which we stand up because they're more functional, because nobody works out or spends all the time lying down, but that's where we need to start. Awesome question, Tracy, thank you. So Emily's question, what type of exercises could you do to stretch out the IT band? One of the things that I've been working on with the fuse box theory is it's my belief, after treating thousands of patients, that I never stretch out the IT band. One of the kind of theories that came up with a colleague of mine is, what if, say you have a tight hamstring, what if it's holding on for dear life because it's the other muscle that's supposed to be doing its job is not doing its job. So if we learn how to activate the right muscles and we learn how to activate, for example, if we activate the glutes in the lower back, the hamstring should relax. If we've worked enough on the glute medius to get that strong enough, and if we've activated the core and we've activated the low back, that in turn should take the pressure off the IT band and they shouldn't really have any issues. Now there's some other things we'd want to look at. Their footwear, that's an important one as well. Some people believe in orthotics, so that's another aspect that we could look at. So for me, I would rather activate the right muscles and the IT band should just relax. Awesome question, thank you. So we have, so the next question I have is, do you feel that orthotics are helpful? I have them in all my footwear. So that's a great question. It's my belief that we need to start, again, proximal to distal, starting close to the body, close to the spine first, and work all the way out. If I've addressed all the issues here with the spine, and if I've addressed all the issues with the hip and the knee and with the foot, that's the last thing I would look at, is then I would look at orthotics. Through my experience, again, I don't remember the last time I had to give someone a pair of orthotics. Commonly, people come in and they'll say, oh, I want to go get some orthotics because my back hurts and my friend told me that I should go do that. To me, that's just kind of treating a symptom of the problem, just like the IT band is. As a result of bad mechanics, you have IT band. If I just worked and addressed your knee, you might get a little bit better, but it's not going to solve the issue, and chances are it's going to come back. Same thing with the idea of orthotics. I want to make sure that I've cleared everything else first, starting all the way at the beginning, from again, the lumbar spine, the hips to the knee, and then we look at the foot last. And if foot mechanics need something, if the foot needs something for the foot, I would rather try a pair of footwear first, something a little bit more supportive. And then if we need to, then we can take a look at orthotics. It's a great question. What are the best exercises for IT band syndrome, and what should I avoid? Well, I think I've already covered what I really like to see people working on is make sure they address the core first. And I would say when we want to address the core, I want to work, if we can work, say with the squat, for example, everybody should be able to do a squat if we've activated the glutes in the correct sequence, in the low back and then the glute in the correct sequence. If we move and just bend at the knees when we go into a squat, that's where people get into problems, and that's why they can have pain. So I always start off people working with exercises on both legs first, and once they can master those, then we can move to a single leg exercise. So if you're having knee pain, IT band pain, any pain around your patella, I don't really believe in doing lunges until you can do a double leg with both leg exercises for a decent amount of reps without any pain whatsoever, because we really need to build up a good foundation. So at the beginning, I would say I would avoid doing any single leg exercises. People think, oh, I want a single leg stance on one leg, but the truth is they really, if you really look at their form, most people don't have enough strength to be able to hold the core in the position to be able to tolerate a single leg exercise, never mind doing a lunge. So I would say I would probably avoid lunges until you're strong enough to do them with excellent form. The next question is, thank you for that question. The next question is, I have a desk job, and by the end of the day, I have sharp pain and swelling on the outside of my knee. Is it possible for non-athletes to get IT band syndrome? It's absolutely possible for non-athletes to get IT band syndrome. A lot of times it does get associated with people who are more active or crazy workout routines, but it is definitely possible. People who are sedentary, people who have a desk job and say they enjoy just reading at home or doing puzzles or playing games, that can absolutely happen there too. And it's, again, usually comes back to the imbalances of the low back, imbalances of the core. So a lot of times doing just some core strengthening exercises and getting a little bit more activity will really make a big impact on that. That's a great question. Thank you. Next question is, I've been told to roll out my IT band with a foam roller. It hurts a lot, and I am not noticing long-term results. Am I doing something wrong? One of the things through my research is I thought a lot about growing up as a kid, playing a lot of sports. There were a lot of things that I started to do initially when I was a clinician, or that you see out there in different athletic sports, is that there's a lot of old thought processes that really don't serve us anymore, but it's kind of one of those, well, I've done it because I've always done it because I've always done it. So I really tried to challenge my own thought process, and I pretty much asked everything I did, I wanted to know, why did I do it? Or what was the purpose, or what was my outcome? I'm really big on, I only want to do something if I know what my outcome is and it's a solid outcome. So it is my belief that the IT band shouldn't really be rubbed or touched, or that we can work all the tissues around it. And I really believe in working on the hip mobility, and the low back mobility, and the thoracic spine mobility. I believe on foam rolling the quads. I believe on foam rolling the hamstrings. I believe on foam rolling the hip and the low back, but I don't really believe on foam rolling the IT band. I've never seen it successful for anybody. I know I see people doing it all the time, and I'm just not sure. I'm not sure why they're doing it, because they don't seem to get any long-term relief. So that's just through my eyes. If you did find some success with it, then I would keep doing it. But for me, through my eyes, I haven't found it successful at all. I have back with the next question. Thank you for that question. That's a really common question. That's something that I see a lot with people. I have back pain on the same side of my body as my knee pain. Are they related? So yes, I would say they're absolutely related. If we look back last week, or the last couple of weeks, we've talked about the lumbar spine. We have all the vertebrae. So we have all the vertebrae in our spine, the lumbar vertebrae. So there's 5 in the low back, and then that move independently of each other. And then there's 5 in the sacrum that don't move, they're fused. At each level of the spine, we have nerves. And each one of those nerves, well, we have the discs in there too. But each one of those nerves goes to innervate something in the lower body. A lot of times, on the same side, say you had a right leg injury, on the same side, I can poke around in the low back and find significant tenderness in the lumbar spine, even if they didn't complain of any low back pain. And in this case, you did have back pain. Some people have back pain, some people don't have back pain, but when I go and check out their lumbar spine, I'm going to say it's high. It's well over 90% of the people with that same sided leg pain do have low back pain. So there is a direct correlation, which goes back to the theory, and that's kind of how I got started. One of the things I got started on the theory of the fuse box is that it's just seeing a direct correlation over many patients that the lumbar spine, and whether it's low back weakness, whether it's abdominal weakness, and which caused the lumbar spine to not move very well, it is directly caused to that. So if you were my patient, I would be addressing your lumbar spine issues before and kind of see what is going to be left after we treat the lumbar spine. But you guys have some great questions tonight. The next question. My son, 11 years old, has just started playing catcher on his baseball team. He complains the outside of his knee of the leg hurts after squatting so long. What can he do to avoid getting IT band syndrome since he really loves the sport? So one of the things that I would say is to make sure, I know nowadays they have for catchers, they have the pads behind your knee so you don't have to squat down as far. I would check out his mechanics to make sure how he goes down to a squat. I would check his low back, see how his core is, see if his core is really engaged the way that it should. I would check out the mobility of his hips, because a lot of times, depending on how they, when they squat down, his legs might be both turned out. So I would definitely check on his mobility of his hip. I'd also see how his knee moves as well. After looking at, make sure everything's moving well. If his lumbar spine is moving well, then I would really get him in a good core strengthening program to make sure that everything's moving well in his low body. And I don't think, as long as he can work on a few mechanics, I don't think he's going to have to stop playing the sport. It's a great question. So I just really want to thank everybody for tuning in tonight. I hope that this was helpful. I'm super passionate, excited about every time I get to do one of these. I actually look forward to it every week. I get so excited when Alana and I talk about the topics that we're going to share with people. So for me, this is a passion of mine. This is a passion of mine. How can I have the biggest reach? And that is a big outcome for me, is how do I have the biggest reach? How can I help the most amount of people? And that's why I started doing the Facebook Live, just to share my knowledge and share my experience, because I know there's a lot of people out there that have a lot of questions, don't like to go see doctors. So if anybody out there has any questions for me, I'd be more than happy to answer at toddh@houghtonphysicaltherapy.com, Todd, the letter H, at houghtonphysicaltherapy.com. Again, I'm excited about this, and I'm really excited about next week. So next week's topic is plantar fasciitis. Hopefully you have some good questions on plantar fasciitis. And it's just been a pleasure to serve you guys again this week. Hope you guys have a great week, and hopefully everyone does well with the snow. Thanks.